7:07. I think we can just
We can
start
start.
basics and
Yes.
introduction by the time Dr.
Yes.
Raj joins us. So maybe I'll start with the introduction.
You want me to introduce?
I have some PowerPoint slides. Is it okay if I do it?
Yes.
Yeah. So I'll just talk a line about BIIPbSAR. So is my slide like visible?
Yes,
Yeah.
yes.
Yes, ma'am, it is.
So BIIPbSAR is a small initiative that four of us have decided that we'll have a joint venture where there are four mental health professionals, and we want to maybe provide quality mental health services in the field of all sorts of psychiatric disorders. And Monday Roundtable is one of the academic initiatives that has been initiated by BIIPbSAR. So the current edition is the 5th edition. Before this, we had around 4, and all of them were quite successful. And we had participants, predominantly postgraduate and senior residents. That is our target. We thought maybe some academic discussion, bring about an interesting case. So we invite again on this forum any person who wants to present a case. We are more than very happy to actually have you here. You can send it across on the mondayroundtable.gmail.com. So today we have the 5th edition. The topic is, where does a psychiatrist go when a patient dies by suicide? And the speaker for the session will be Dr. BIIPbSAR. He is currently a senior resident who is working in our department at KIMS, Bhubaneswar. We have our discussant, Dr. Arun, who is professor in CMC Vellore in Psychiatry. And we are expecting Dr. Rajnarayan Maswar to join us soon. We have Dr. Jaiprakash Russell Ravan and Dr. Udit Banda, who are our in-house discussions. I would like to request Dr. Jaiprakash Ravan sir to kindly introduce our external guest discussions, Dr. Arun and Dr. Raj. Dr. Ravan, can you please do the needful?
Very good evening to one and all. Welcome, Professor Arun. He has been associated with CMC Vellore for more than maybe 12 years. He passed his master's in public health in Sri Chitra Institute, and then he did another master in, that is MD in psychiatry in CMC. And after his MD, he continued to lead the rehabilitation service and with Professor Anatharyan, and he has been working since then with that Unit 3 of CMC Vellore. He's actually very good teacher, as well as he's a very good service provider in different domain, and mostly in the field of staff mental health, and as well as in the area of community rehabilitation. And currently we are fortunate to have him today, and we'll see that how we can discuss about this sensitive issue and try to learn from each other experience, as well as from some of the evidence in this regard. Thank you.
Thank you, sir, for the brief introduction. May I now invite Dr. BIIPbSAR to kindly provide us a brief overview of the case and the difficulties he faced, particularly after the unfortunate incident of suicide happened. Maybe he'll scroll us through the incident, and then we can open the forum for discussion. Over to you, Dr. BIIPbSAR.
Thank you very much, ma'am. First of all, I would like to say good evening to everybody present here. And I would like to thank BIIPbSAR for giving this opportunity. First of all, we'll discuss briefly about this case. So I think my screen is visible to everybody.
Yes, sir, it is visible, sir.
Okay.
Sir, could you do it in a full screen mode, sir?
Sure, I'm trying.
Yeah, it's visible, sir.
Okay. So today's topic is, where does a psychiatrist go when a patient dies by suicide? So this is an actual incident which happened to us recently. So this patient was a 21-year-old male, was pursuing graduation, was unmarried, was the only child of his parents, belonging to an urban background and an upper socioeconomic status, presented to us with complaints of low mood, loss of interest, decreased concentration in studies, unable to attend classes regularly due to feeling of excessive weakness, feels like his life is worthless and he cannot do anything in future. So, and his main complaint, persistent complaint, was his parents did not give any importance to his mental illness, in the sense that they did not acknowledge his illness. They thought that he was just making up things to gain attention. And according to him, the duration of illness was 8 months. A diagnosis of moderate depressive episode was made and treatment was started. Initially, we started with pharmacotherapy, like we started an SSRI along with benzodiazepine, which was optimized over a period of 1 month and continued, and the benzodiazepine was tapered and stopped. After 1 month of starting pharmacotherapy, we started non-pharmacological management also, like psychoeducation and supportive psychotherapy, giving an insight to his own illness and how to cope with it. Like we taught him relaxation techniques, coping skills, attention enhancing strategies like mindfulness, breathing, study skills training. And finally, we called his parents to our OPD and psychoeducated them about his illness. We basically took 2 to 3 sessions of psychoeducation of parents. And all these things were done over multiple sessions over a period of 4 months. But suddenly we got a news one day that the patient has committed suicide by hanging himself in his hostel room. So I would like to mention a few things which we noted during the treatment. First was just his frequency of visit to the treating team increased in the last 2 months. And such that he visited every 3 to 4 days in last 1 month, though he was called every 2 weeks. And his last visit was 1 day prior to committing suicide. But to our surprise, that day he looked visibly improved and thanked everyone for their help. And same day he shared his photo in social media with caption like mental health matters and mental health awareness. And the most important thing is that we got the news from the patient's father, who called us and informed that that his son is no more. He was obviously distressed and disturbed, but he did not blame us for his son's suicide. And obviously the whole treating team was in shock because the suicide was never expected. So today we'll discuss, like we want to know from our discussants, like how to deal with it. Because this is like our first incidence in a while. So before we go to this topic, I'd like to mention a few points which is given in a book called If a Patient Dies by Suicide, a Resource for Psychiatrists, which is endorsed by the Royal College of Psychiatrists. Some things that are mentioned is that prediction of suicide is...
Dr. Bishwajit.
Yes, ma'am.
Yeah, can we hold this for some time? Maybe we can open a discussion by our discussion. And then maybe finally you can summarize whatever recommendations you have come in for the vacant record.
Okay, sure, ma'am.
So at this conjuncture, I would like to request Dr. Udit Banda. Just before we thought of taking up this case, we were having a brief discussion about what are the questions that cross our mind when such a case happens, and what is the initial response that we go through. So Dr. Udit had a few very interesting questions in his mind, and we made a small slide on that. So I'd like to request Dr. Udit if...
Because it's okay. Without the slides, I'll probably speak.
Okay. You want the slides to be there or not?
No.
Okay. Okay.
Biswajit, Dr. Biswajit he works in my unit. So he called me up immediately after we got the news about the demise of the patient. I got reminded of an event that happened to me in the initial days of COVID in 2019. I was at Nimans, and I had a patient under my treatment for the last 6 months. He was a medical professional with alcohol dependence and bipolar affective disorder. When everything seemed normal, a day before a scheduled follow-up visit, he died by suicide, with a gunshot, self-inflicted gunshot injury. I was very confused. Those questions actually flashed back again, because that's kind of a grief that I probably never fully resolved in my mind. The topic that was decided, it was decided a week back, and after that I did some reading. Apparently there is something known as a twin bereavement when a psychiatrist or a therapist loses a patient. Twin bereavement in the sense that you bereave the loss as a human being, as a person, and also you bereave the loss as a doctor or as a medical professional. So the first question that was in my mind was, is it my fault? Did I do something or did I not do something? Was there an act of omission that is responsible for the outcome? I put the word responsible in quotes, responsible for the event, or I did not do anything. I missed out on some of the issues that had actually done it. The next question was, should I talk to my colleagues about it? Are they going to judge me? Are they not going to judge me? Do I become a bad doctor or bad therapist if I talk about it? Then the next question, do I speak to the family? Do I express my condolences, or do I just hide and lay low till the whole grief for the family passes out? That was the next question that I had. Finally, how do I make sense of my emotions relating to this event on a longer run? Because gradually, as happens with every loss, you gradually get over it, but there will be situations where you are reminded. Maybe it becomes localized, in the sense that when you see a patient with similar profile, you get reminded, you get a little scared maybe. In this instance, he was a student. So next time when, I'm sure when Dr. BIIPbSAR sees another student, he will be reminded of this event. So those are the questions or the doubts that I had. Some of it is still there. So I would request our esteemed discussants, panelists to please shed some light on these topics or anything else that they want to talk about. Over to you, Jigyasa. Thank you.
Thank you, Dr. Udit, for raising those very pertinent questions at this point of time. So if I come to the first question, is it my fault? Was it an act of commission or omission? I would like to invite Dr. Arun. Sir, when we have this question in our mind and we feel some way responsible, some way or the other, how do you think we should handle it, or what is the usual perspective that you would provide in this particular scenario?
If possible, I would like to raise a question to Dr. Udit. So before that, I think it's an unfortunate incident for the individual, for the family, BIIPbSAR as a treating doctor and Udit as a treating doctor. But since Udit has had this doubt, did I make any mistake? If possible, can I ask Udit, why did you think so?
So, sir, the last session that I had with the patient, my patient, which happened in 2019. So, I talked about everything. I optimized the dose of medication. I explicitly did not ask about suicidal ideas. That was something that I did not do. I had done it in the initial stages when the symptoms were very florid. But mind you, it was like 5 to 6 months of follow-up. After that, this happened. And he visibly seemed absolutely okay. The family also corroborated it. He has started going back to work. He's absolutely functional. We are very rarely see the emotional symptoms that we are seeing. His alcohol use had come down. So that's why I probably thought maybe it was a mistake on my part who did not ask about it.
So basically you mean to say, because since you had the 6 months of journey with the patient, you are confident that the person's mental state has improved from an illness state to a probably pre-morbid level, which is also corroborated by the family members, which is also being reflected in his functioning. So in all those domains, the person has been showing an improvement.
Yes.
Right. So in that being the scenario, then why do you think that I didn't ask suicide at the last minute?
It did not make sense. I'll tell you what I did. We actually keep our treatment follow-up records digitally. So I actually, I probably multiple times, maybe hundreds of times, I would have opened the whole sheet of follow-up records. I would go through the notes. I would see that on paper, he seems that he is getting better. So that the sudden decision to end his life did not make any sense to me.
Sure. So my since the question is like what how to answer this question, because the reason why I've been asking this question was because, see, from whatever description that you give about your particular individual or a client, sounded as if there was no reason for you to ask about a suicidal ideation on that particular day, right? Because it's also true that we cannot keep asking suicide ideation to everyone every time, right? So you made a clinical judgment, accumulating all the information from your all follow-ups, from the family report, from the functioning, from the cross-sectional finding, and which made you decide that it is not necessary to ask about suicidal ideation on that particular day, right? So that being the case, how can that be your fault?
Yes.
That was there in my thinking, but sir, I'll tell you, nevertheless, I felt what wrong.
Sometimes maybe this rational thinking, although back of our mind, we do know that we have practiced to the best of our clinical judgments. But because something unexpected happened, so we start questioning our own abilities. Maybe we have decreased confidence on our ability as a good psychiatrist. So this is something which a lot of people also describe, is what I found in literature. So at this point of time, I would like to ask this question to Dr. Ravan. Do you think it is a good idea for this psychiatrist who has lost a patient to suicide? Should he or she talk to his or her colleagues about it? Like, how should that happen? Because usually the thing is what they will think of me. They will think I'm incompetent. They will think I killed a patient of suicide. So these are the perceptual things that go on in our mind. So what advice would you give to them? Should a psychiatrist talk to them?
This is a very good thing. I actually, thanks to BIIPbSAR, to be, it's actually intellectual honesty. When in the clinical scenario, when you develop counter-transference, when you develop transference, we need to go and talk to the colleague or supervisor. When there is a remission, our patient gets some healing, some job or some marriage, or they get child, we feel happy. In the similar length, we have to take that when some patient, even if there is no acute psychological or psychiatric crisis, people commit suicide. So we know suicide is preventable, but all suicide not. And it actually is the essence of debriefing or an analytical session with the colleagues and the residents of that unit who are directly or indirectly involved in that particular patient care. When you sit in a round and discuss that this thing happened, I am feeling guilty, I am shameful, I am feel like crying, with all emotions are okay. But as Arun asked Dr. Udit, it is like a role play. Like, what do you think that why you are feeling guilt? And then when somebody says ki, there was no need to ask suicidality, or there was significant clinical improvement, I was thinking, or we are thinking that patient is settling. At the same time, this crisis happened, or this acute attempt on life happened and patient passed away. So that itself gives, as Dr. Jignesh was saying, that cognitive error or some kind of cognitive distortion which the therapist has because of this acute stress reaction in him or her, actually will change. yes, why I'm getting affected? Yes, anybody will get affected because he or she has worked 6 months of the patient's life with the process of therapy, or 6 years of patient's life with the therapist. So everybody will be affected. But sitting and discussing because we have to have this preserved time to re-examine the background and why it happened, how it happened, what could have been done. If we have done almost everything in a good way, then automatically the guilt will come down, and then the sharing of senior people with their incidents of this thing in the past also helps. Sorry.
This brings us to a very important point right now, that discussing with our own colleagues, seeking supervision, having a structured debriefing with someone you trust. These may be very the real help that a person who's handling a patient who's lost with suicide can actually get. But many studies have also highlighted here that maybe our residency training is lacking in our ability to handle this particular issue. Like, we do talk about how to prevent a suicide, we do talk about how to assess for suicide, but maybe there is a bit of silence, like what happens, what to do when actually a patient is lost to suicide. So with this, we come to the next question. Should I talk to the family about the event? How do I face the family? How do I face the suicide survivors? Because obviously that is again a very complex situation. So I think Dr. Raj has also joined us. Sir, if you can switch on your video and audio, we would be really glad to have your inputs on this point. So how do we approach the family in such a case, sir?
Should we
Hi.
call or not, sir? First, that was the doubt.
Sorry, I missed that question.
Sir, so in this scenario that we have lost a patient to suicide, is it a recommended idea to get in touch with the family or not, or it is case specific, or how do you go about it? Because sometimes the family actually might be grieving and they might need support, so that is something that is there. So as a mental health professional, you feel compelled that you go back, plus there is some sense of responsibility as well, because you're dealing with the lost person. Then it might, the contrary might also happen, that people start blaming you for the loss. And in that moment, your guilt and your negative emotions, they kind of magnify. So what would be a better idea, whether to talk to the family after the patient is lost or
not? Thanks for the question. Am I clear?
Yes,
yes, sir.
Yep. Sorry, I missed the initial part, but I got the gist of it. The two things I would like to state. First is I might inject a bit of westernized view because of the area I work. So to answer point blank, the question raised right now is, should we inform the family or not, and what implication would it have? Something what we do as a common practice here is open disclosure, which means immediately once that happens, that event has happened, or we have realized that has happened, we let their next of kin, like closest family member, know that that has happened as a matter of fact, like that, without any explanation why that has happened. We just provide that information and then offer condolences or offer them a meeting to come and catch up. And the implication of that are twofold. First is obviously, as Udit has already highlighted, to provide support to them, because we know it has got a contagion effect of, not only in terms of depressive syndrome, but also suicidality. So to provide support to the closest family member. Plus, second thing is the further investigation. We all live in an increasingly medical legal world, and that will come to your defense when there is further investigation, whether, like in my context, coronial investigation. So to answer that point blank, yes, we must inform the family. Of course, there are concerns of you being blamed, irrespective whichever way you go, whether you inform or don't inform, that risk is going to be there. I was wondering if I could just interject something from the previous question about why we feel this way. One of the key things when we look at suicide is it's like the question we need to ask: if I am a physician and I am working in a medical setting, let's say in ICU, well, when a patient dies, how does the physician feel? Are our feelings different to theirs? That's one thing we need to answer to ourselves, because death happens in medical settings. So psychiatry is a medical setting, so death will happen. Second thing is, as a professional, we are trained, or we are expert to come up with something, to come up with a figure where we say likelihood of somebody is attempting suicide, low risk, high risk, or no risk, something like. No, it is never no risk really, but kind of a grade we give. So that is called predictability. So I predict this person who is under my care, because of the static risk factor and dynamic risk factor, these are the risks. The person is at a lower risk of suicide. I never say the person is never going to commit suicide. The other aspect is detectability. So detectability is I detect that this person is going to kill him or herself exactly at 3 a.m. on 15th of December, whatever. Now, if I am confident to detect that when that is going to happen, then I can prevent it. But that's not we are capable of at all. We are only capable of what we call as predictability. So we can only predict. So that means when we're assessing our own competency as a doctor, whether I did something right or did I do enough to prevent that suicide, that's completely a wrong way of looking at our own expertise, because we are simply not capable of doing that. We are not able to, we don't have the technology to detect when who is going to attempt suicide, whether that is going to complete suicide or not. We are just good enough to come up with some kind of conclusion, some kind of idea, whether there is a likelihood of the person committing suicide or not. Now, the person might be traveling really, really well. He has seen you or she has seen you. Everything is fine. From leaving your appointment and on their way home, thousands of things could happen, which could trigger thousands of different negative emotional responses, which could lead to a fatal outcome. Now, you can never be responsible for the outcome. So, at the beginning of training in psychiatry, that needs to be drilled into our core competency, that we are not capable of predicting that. And there is enough literature available which supports that that notion that we cannot prevent suicide. That's a fact. So if we have to practice in psychiatry, we have to accept people could die even though we have done everything. So that's, sorry, that's going back to the previous question. And yeah, that's it.
See, with permission from the chair, I would just add a few anecdotal thing with my experience. If you don't face the family in the few hours or few days after the suicide, or you try to do active avoidance to them, it might take years to again make a meaningful eye contact and conversation with them. So what happened, one of our nursing staff, brother, got admitted in 2015. Following discharge, as you expected, he stopped medicine, found sitting in a tree near a hilltop. People tried to bring him back. He did not come. It was dead night. So they thought, okay, next day morning we'll come and rescue him. Next day they found him hanging in the same tree. And the nursing staff, I could not make a conversation with her, and I was young to this field. And you won't just trust me, it took 7 years Just the last week, when my father had a dressing wound of one injury, and the nursing staff used to give the dressing, she's the same person whose brother is lost because of suicide, and took 7 years from 2015 to 2022 to make a conversation. And the role is also now changed. I have gone as a patient relative, and she is the care provider. So if it is not done in a professional way, in an empathetic way, just to go there or to listen to them, they might blame to some extent, but it's okay to just listen, not react or respond, but to be there. And then that will, as our experts are mentioning, it will reduce the chance of legal implications, as well as also it gives or makes a pathway or future conversation open. So it is very important, if there is an opportunity or option of talking to one of the relatives or close caregiver, we should go ahead and do it. And sooner is better.
Thank you, sir, for very candidly summarizing it. I think Dr. Arun has a point to make, so please go ahead.
Yeah, as Dr. Raj has rightly pointed out, there can be a cultural variation, and the way we respond might vary how we respond in a Western world and in the Eastern world. That is something which we need to keep in mind. Second thing, I just thought of sharing the practice here because, for example, BIIPbSAR is now presenting this scenario as first year SRship. So in most occasions, what happens is like it is the junior most person who might be facing this kind of a critical event in their practice. So at that point in time, what we do in our institute is like rather than we sending or forcing the SR to deal with it, there will always be a senior person with the SR or a postgraduate, so that, because the problem otherwise would be the SR or the postgraduate will already be going through a grieving process. These questions will be there. Did I do something wrong? With that feeling tone, approaching the family, and then if at all the family raises some blame on the individual, it can be sometimes too hard for the individual to handle. So instead of single-handedly managing that, I think having a team approach while dealing with the family might be of help. I'm just sharing what is being practiced in my unit.
So I think this seems very pertinent to our case also, where here the family themselves come and report that something like this has happened. The family themselves come and share the news of suicide, instead of maybe in the Western culture where we have to do the disclosure part. So Dr. Vishwajit, if you can share your first-hand experience of what exactly were the initial emotional responses that you had when you dealt with the case.
Ma'am, when his father called me and said that my son has committed suicide, I thought that's some attempt, non-suicidal self-injury or something, cutting wrist and something. I just asked him, is it serious? If this is not serious, please bring him to the casualty, we'll go and see. He said, no, he is no more. So I was blank for 2-3 minutes. No more? What do you mean no more? Yesterday only he called, he said he's good, he is better, and thanked everyone. I was in a shock. Then I didn't know what to do. That's why I called my unit senior Udit sir, and then my HOD Professor J.P. Ravan sir, and informed him about this thing. So I didn't know what to do. The only thing I did was inform my seniors. Sir, here I have one question. The family itself themselves called and informed us about this thing. They have never blamed us that you did something wrong, or it is because of you my son committed suicide. But sir, we never had the courage to call them back and tell and comfort them or something. So here we did not know how to react or respond. So I could have responded in this case, sir. That's my question.
May I?
Yes, sir. Please, sir.
So as I was telling the anecdote, it is actually, if you gather some courage and call and tell I am going through a lot of pain, and I am also getting his memories and our conversation and all, they will identify that that is a grieving process, and they are also in the same, maybe in a very intense way, because for them it is a child, for us it is a very important patient. But your grief, your feelings is in tune with their feelings, and it is no harm expressing it. Even no, it is not that if you break down or cry a bit or cry to some extent, it will be non-therapeutic or something like that. If it is that it's a genuine emotion can be expressed, and it will not, it will actually go in a long way in future relationship with the community and this family in particular.
Sir, but I have one doubt that can this be counterproductive? Like the family members might think because you have done something wrong, that's why you are having that guilt and calling us back. Because in our society, this is expected, sir. That's why you have to go very, like, I don't know, cautiously.
And that's the reason, if you have that amount of that kind of doubt in that it is get because of the acute fight, then it is safe to talk to among the colleagues. Maybe 1 or 2 sessions of debriefing will help. With guidance of seniors and other colleagues, we can take a necessary. In case to case, it varies. If they are nearby, they are very close, then a telephonic contact, and from that we can analyze their mood, and that will help us whether to go and meet or not. Somebody asked in another forum that whether we should go and attend the funeral, or we should go on the 11th day or 12th day to their home. It is the wiser is actually the whatever I understood, that not to go to the person's place if it is not very, very essential. So better to have discussion among the colleagues and have more understanding about the incident or kind of this event, or this event might happen to anybody, any professional, or mostly any mental health professional, that we need to understand.
Thank you, sir. I think with this, we have a very few interesting questions in the chat box. Dr. Anand Prakash says, why do people attempt suicide when they appear to feel better? I think this was the case in Dr. Vishwajit's case, and also the case that Dr. Udit Pandya described. So that's a very interesting question. Maybe Dr. Raj can take it up. What do you think?
At one point, the classical teaching, what it says, that when people were suffering from depressive disorders, they're exposed to antidepressants and they start feeling better. They maybe gather up the courage to commit the act of self-harm, because the ideas, the negative for the depressive cognizance are still there. That is the, but this is
one. And another thing I have to say here, maybe sometimes a patient contemplates suicide, and the person is very sure that I'm going to commit suicide. That thought itself maybe helps the patient to feel that this pain is going to end, and there can be a temporary phase of feeling better. So that can also be another possible explanation. You have something else to add? So maybe Dr. Raj can comment on it further.
I think suicide is a very complex phenomenon. When I was a medical student, when I was very new to psychiatry, the teaching was any kind of suicidality actually reflects underpinning mental illness. But as we have come to a better understanding of suicidal behavior, where the contemporary understanding is not actually that. Suicidality or suicidal behavior remains on its own across the society among people who are otherwise considered normal. Yes, if someone has depressive illness or a mood disorder, their risks of suicide are higher. And as there is static risk factor and the dynamic risk factor, we have seen the person was well and something has changed that has triggered, or going back to, there is a change of medication, the person was anxious and that's why that has happened. It is completely different to that. The person was recovering and there's a completely, social breakdown in the network, there's a relationship breakdown, which has resulted in suicide. When we do the autopsy, the investigation after that has happened, we come up, or the coronal investigation, we come up with some kind of conclusion, or some kind of theory. Suicide might have happened because of this, right? But the truth is, no one knows why suicide happened, because the guy who actually knows is no more. So we will never know why the person committed suicide. So, psychiatrists as a profession have invested too much in defining that and finding out why that has happened so that they can prevent. But the truth is, we have failed terribly. We cannot predict suicide in most of the cases. And when we see someone, that is actually research, when we actually see someone and with our assessment consider them as higher risk, they actually don't commit suicide. But most people, when we have assessed them as they are traveling well or they are at lower risk of suicide, they actually commit suicide. So, it does not work that way. So we have to just accept that's fact, that's science, and that's how things evolve.
Is it safe to conclude that the psychopathology of suicide is not yet fully understood, and the responsibility of the act is multifactorial, so the blame cannot be laid upon a single factor, be it a therapist or a treatment failure or a life event?
Completely. It cannot be pointed out on a single, or blamed on a particular factor being absolutely responsible for that. It is always going to be multifactorial.
Thank you, sir. I think we have a few questions on the medical legal aspect of it. Shripati Santosh, she mentions that there's a patient who got admitted in acute care, committed suicide in front of the family members. Mentions of another case where a patient was in the rehab center when the patient committed suicide without any family members. So these are two different situations. And the question is how to deal in these situations from medical legal point of view. So maybe Dr. Arun can comment on this. Sir, your opinions, please.
I think at an institutional level, what you should be having is a protocol and ensuring that the protocols have been followed, not just on papers, but in practice. So, because for most of the medical legal issues, the problem happens when actually there is a negligence. So if we have systems in place, as Dr. Raj rightly pointed out, suicide is an outcome or an endpoint of many factors. And we will only be able to predict it, we will not be able to prevent all suicide. So that being the fact, it will be accepted in a court of law. What the court of law or the legal perspective will be like, have we done enough to prevent it? Which includes the risk assessment, the precautions that we have taken, and the measures that have been taken in and around that attempt. So all these things. So it's not the act or it's not the outcome which matters, but what all we have done is what matters, is what I understand. So for example, in our institute, what we have a suicidal risk assessment. So people who are predicted to have a risk are having a serial suicidal risk assessment. And we also have a documentation as well as a interaction with the patient and family members, how to bring down that risk, both pharmacologically, non-pharmacologically, as well as within the system itself. Avoiding access to harmful weapons or anything of that sort. So if those things are being followed, we will be able to prevent a few suicides. If at all, over and above, if something happens, it is evident that we have done enough to protect the patient.
Yes, sir. So with this, I think we have come to the end of time, but I think we can take the next 3 to 4 minutes to allow Dr. Biswajit to maybe summarize the guidelines that he has gone through in the last few days. I think he had some 2 to 3 slides on that. So yes, Dr. Biswajit, would you do that?
Ma'am, actually all things has been already discussed, but still I will
You don't have anything new?
One point I'd like to make, it's something that I read. apparently a lot of suicides, they happen after the people or the patients, they get in touch with a mental health service. So maybe within 2 weeks after discharge, or after the first few visits to the hospital. So it actually reflects a more complex process than ascribing it to a single person or a single event. So that is something that you should keep in mind when situations like this come up.
I was also going through a Lancet editorial that was published recently. The prevalence of it is like out of every 2 psychiatrists, one of them will see a patient who has committed suicide. And out of any 5 mental health professionals, there will be one who will see a person with suicide. So it is that common, like 50% of psychiatrists and 20% of all mental health professionals together. So with this, that it is so common.
Can I say something
sir?
before you end? So, like what for the youngster who have joined and the early career psychiatrist, actually, it is if your patient commits suicide or you are in the part of the team, better go and sit in front of your supervisor and take the team and discuss. In can also include the paramedicals, nurses, and all. They have also their point to also mention and the feelings to be expressed. That is one thing. Second, one very interesting and very enlightening thing, when somebody did a qualitative research on the mental health professionals about the incidence of suicide happened in their respective professional career. The question was whether this event of suicide in their professional life made them worse or it has made them better as a professional. Everybody has written that it has made them evolve as a better therapist or better human being, because they started understanding that the limitation of a psychiatrist or a mental health professional in a very harsh way, but that is the reality. We have limitations that we have to understand, and that a suicide in our life in a patient's life in our professional career is not a failure to our attempt to give mental health care, but it is an event which is anyway inevitable. So these two things is very, very important. And how this family can come to peace in loss, that is that should be the like our end point, and that can be facilitated by a therapist with wisdom that can be facilitated. So these are my concluding remarks. It is over to other people to say, or the moderator to wrap up.
The last concluding remarks from our other discussions. Dr. Arun, your concluding remarks, sir.
Yeah. One thing we can practically do as of now is like sensitize the consultants as well as a postgraduate, because when a postgraduate joins for MD psychiatry, a postgraduation in psychiatry, they're being taught how to manage a violent patient, how to do a suicide risk assessment. But that this concept like suicide can be inevitable in a minor proportion of our patients. And what can be done if such an unfortunate event happens has never been taught in the curriculum. So I think the senior people should also be knowing all these things. We should actually transfer this knowledge to the juniors so that they don't hesitate. When such an unfortunate event happens, they will not hesitate to approach the colleagues or other members. That is one thing. So as a disclaimer, I will just say that to the previous question, I have given my comment as on a capacity of being a professor in this institute, but I'm not a legal expert. So that should be kept in mind. Okay, so because medical science and legal aspects can sometimes differ. So whatever I have given my opinion as a legal thing is not on my capacity as a legal expert, but as a professional. But it was a good topic, and
thank you, sir. May I request Dr. Raj for his final comments on the topic?
I think I'll take that from what Arun had just described. I think very early in psychiatry training, this must be very explicit that suicide is a rare thing, but it can happen. It's kind of normalizes the whole process of helping someone who is at a potential risk of committing suicide without having significant self-blame. That's number one point. Number two is I think all the hospitals or the institutes, they should have their local policies and procedures to be there, so that the younger generation, like the trainees or early career psychiatrists, they are not confused. If this happens, what I should be doing? I should talk, I shouldn't talk. It should be protocolized so well that we just follow exactly the way the protocol dictates, and then obviously talking to colleagues and having a peer support and talking to supervisor should be part and parcel of this process. Right now we are in a stage where there are a lot of self-blame that, did I do enough? Did I not do enough? And we are struggling with that, and that's happening mostly because we don't have a system which will support the doctors who are early in their career.
Thank you, sir. Your concluding remarks, Dr. Udit, and with that, we wrap up the session.
No, actually, that this is something that I have been recommending to people time and again. I have, in the last 1 or 2 years, I have started training people in psychiatry. So I always discuss about the experience, the learning from it. That is what all our seniors are also recommending. So I think it's the best. Things like this will keep happening, and if we're aware that something like this should be discussed and maybe taken up in a positive note, so the grief gets better, you become better as a professional as well.
Thank you, sir, for those remarks. So with this, I think it's time. Let's start 8. So we conclude with the 5th edition of Monday Roundtable. Thank you all for joining, and special thanks to Dr. Arun and Dr. Raj. Thank you, everyone.
Thank you, sir.
Thank you.
Thank you, ma'am. So from here now, I'm ending this meeting. Have a great evening to all.
Vishwa, thank you so much.
Thank you, Vishwa sir.
Thank you so much for your honest and a very lucid presentation. Thank you.
Special thanks to Sarmista Madam who has joined.
Yes, and Dr. Avinash Kamath also joined,
Oh.
my fellow colleague from St. John's. Okay, thank you everyone. Good night.
Thank you.